Okay, I want to thank the committee and Dr. Shishebor for inviting me here. I actually try to do my best to keep it in 8 minutes, so I might move a little fast, might be a little bit basic, but I'm going to share a couple examples. So this patient actually is a 38-year-old male who is a heroin user, and he injected between his first and second toe and basically caused an amount of severe vasoconstriction. So he was sent to an outside hospital, another hospital in the city. Then I just got consulted on this patient. We went ahead and did a TMA. We let it demarcate to some degree, but unfortunately, a lot of this with the heroin, whatever else was in there, caused a significant amount of micro damage to the vessels. So this is what we're kind of left with to kind of see what we could do at this point. Next is that this was a patient, a 65-year-old male. He presented, had end-stage renal disease, had osteomyelitis, and went ahead and did a TMA on this patient. Obviously, his wound dehisced with that, but we want to get a patient from a wound that looks like this to completely healed like that. So what are the steps that we're going to do? And a lot of this is a review of what everybody else has said, so it's really good build-up for everything. So I kind of looked initially at TMAs, even though it was a general statement for amputations, but this is listed in the order of predictive healing, with the worst being at first. So obviously patients that have any type of amputations due to vascular disease or vascular status have a very low risk of healing. Infection comes after that, and then traumatic amputation. But if you look in the literature, what they're recommending or what they're stating is that roughly only about 50% of the patients that have TMAs do heal. So we're kind of flipping the coin with these patients. This is an old study. I know Dr. Botek had mentioned it. This is from JBJS in 1976. But what they did was take a look at the energy cost of amputees. And the reason that I included in this is sort of what Dr. Botek said about the functional amputation. But if you just take a look, and this is a 40-year-old paper, but if you look at the amount of oxygen uptake at the vascular amputees, starting with the cyme and going up to the above knee, you could sort of see that the oxygen uptake is significantly less with a more distal amputation. So that is obviously what we're trying to do, is keep these patients a little bit healthier, for lack of a better description, so that it's less effect on their heart and their lungs. So what do we do? What are the basics? And this is just basic wound care, what I like to follow. It was wonderful to run in a couple of my former residents here. But this is some of the things that I always stress. So obviously, sometimes we're doing these amputations. Patient comes in with gas gangrene. Sometimes we're behind the 8 ball. We can't have a full vascular workup. So obviously, we check the pulses. The big thing is that if something is not palpable, is it operable? And I'm always a big proponent of everybody that treats lower extremities, whether it's a wound or not, should have a Doppler in the office. It's $100 off of eBay. Even if you can't get waveforms, you can at least listen to the sound of the waveforms with that. Obviously, sometimes we have patients that the graft went down. So we need to do other tests to see, and obviously get them into a vascular specialist, for possible intervention with that. What about imaging? I think Dr. Botek, Dr. Maier has both talked about serial x-rays. I think that's really important. Once this patient has a dehiscence, I send them immediately for an x-ray, and then I'll have them come back on a weekly basis, but maybe every 2 weeks grab an x-ray. I don't think you need to run for an MRI so quickly just because of the cost with that, but if there's some questions on the radiographs, there's no reason why you shouldn't get that. I don't have access to the Luna or the SPY, which are able to check the microcirculation on the angiosomes, but that's also something, if that's available at your facility, is a great idea with that. So what is the treatment? Obviously basic wound care, and my big thing is debridement. Okay, we have to be aggressive with these debridements. I'm a big fan of bright lights and cold steel. Take a scalpel to these patients, take a curette to these patients, but you have to be very, very aggressive with this debridement. Sometimes, you just have to take them to the operating room. That's where you're going to get your best debridement. You can control a lot of things. I know a lot of times in the clinic, you're trying to do an aggressive debridement, and the patient's on Plavix or Coumadin, whatever they might be on, and there's a pool of blood on the floor. So sometimes it's best to get them into the operating room. Obviously, bioburden should be addressed. You could take a culture of the wound. I usually kind of hold off on any antibiotics unless they're clinically infected with that. There's some companies now that are doing these DNA type of cultures where they're looking at what bacteria might be present in the wound, but unless it's clinically infected, I really don't think you need to treat it with that. If it's a long-standing ulcer or a long-standing post-op wound dehiscence, take a biopsy. Okay, there could be something else going on. So there's definitely some other things that we need to talk about. I like to see my patients post-op, especially if they have a wound dehiscence and it's not looking good. They have to come back every week. You can't wait, 2 weeks to see these patients. So, and obviously keeping the proper wound environment, a moist wound environment. So whether it's daily dressing changes with some type of antibiotic ointment or a hydrogel or some other product, I think it's best to do it daily with that. But with our vascular patients, we have to put in these other comorbidities. Obviously, renal disease, patients with end-stage renal disease, whether it's 3 or 4. We know that we're behind the 8 ball with that. We really have to be aggressive. We can't wait on them. And like Dr. Carmen said, it's a team approach. Call up the nephrologist and say, hey, Mr. Smith's creatinine is 3.5. We need to do something with this patient. Previous history of an amputation. Have these patients had toes or re-amputated? Do we go to a TMA or do we go to something a little bit more proximal but still keeping it distal to the ankle? Elevated hemoglobin A1C. I was the residency director for 10 years at the VA. I was happy to see a patient that had something of an A1C of under 9 that had an amputation. So obviously talking with the endocrinologist and try to get these patients a little bit more glucose control is going to help with these amputations to heal. Also, too, don't forget the nutritional status. Take a look at the albumin and pre-albumin. Those are very important, too, that sometimes we just kind of overlook those things. So get a nutritional consult if you need to. And then finally, too, if this patient's had this post-op wound dehiscence in more than 30 days, we need to be very aggressive with these patients. So like I said, minimal improvement, we have to be aggressive. Take them to the operating room. If you're able to debride it down with the scalpel, if you want to use the hydrotherapy devices or ultrasonic devices to debride these wounds, if you have a good granular wound bed, then go ahead, do a split thickness skin graft. It's the gold standard. Go ahead and put that on, or use an allograft or a xenograft of your choice. But we shouldn't wait on these patients because we want to basically keep them to have a functional amputation. So what's next? Sometimes with these patients, I'll go ahead, I'll debride them, I might do a skin graft with them, but I like to do adjunctive or multimodal therapy. And basically the best way I could describe it is it's kind of like making soup. You need a good stock or base, which is obviously good wound care with that, but like Emerald says, you need something to kick it up a little bit. So when you're making soup, you add different spices to it. So sometimes we need to add some other things. Obviously, hyperbaric therapy, is something to definitely be considered, but this also takes a commitment from the patient. You need to make sure that the patient's willing to do, at least 20 to, 25 dives in a month to get this to heal. If they're not going to commit to go every day or during the week, it's worthless for that. And then obviously too, negative pressure definitely can and I wouldn't say should be, but is definitely a good treatment option to be used in conjunction with that. So what about further amputations like the gentleman who was the heroin patient? Skin coverage is very important. So the next level would be Shichebor's. So you're leaving the calcaneus and the talus. But if you could barely get the skin closed, I've done it unfortunately too many times to try to get closure. If you put too much tension on that wound, it's going to dehiss again. So sometimes it's better to go to a little bit more proximal amputation. That's a Symes amputation. And with that, there's a lot of discussion in regards to how functional that is. You talk to some of the orthotists, you talk to some of the vascular surgeons. They say it's not as functional as having a transibular amputation. But it's definitely a decrease on the load, as we saw in that study, on the load on the heart with that. And then finally, a transibular amputation. If you have a patient that's relatively healthy, they're revascularized, they're diabetic, but they're in relatively good control, sometimes it's better if their TMA fails, go right to the transibular amputation, get them fitted for a prosthetic. Usually the BKs, heal a little bit faster. They could get them in a prosthetic and get them walking a little bit quicker with that. So that's all I have. So I thank everyone for their attention.